Good morning and greetings from the southern end of Africa. It is indeed an honor to me to be a part of your meeting today. My thanks go to the organizing committee and in particular to Professor Mona Salem and Mona Hassan for their invitation for me to be able to present today. I am humbled to be asked to be talking about type 2 diabetes, particularly as it pertains to developing and middle-income countries. Please excuse me while I find my slides. Scientific data on this subject has been sparse and limited to studies done in developed countries, predominantly in the United States. A perspective from developing and middle-income countries is sadly missing at present. I have elected to discuss the subject from my perspective as a practitioner in a developing country. This slide is taken from a recent set of guidelines and echoes diagnostic criteria for diabetes as proposed by the major players in diabetes. I do not need to inform this audience of these criteria. It has often been said that diagnosing diabetes is one of the simplest diagnoses in endocrinology. However, in this situation, the next step can be a bit more complex. When I was in medical school, it was easy. Diabetes in childhood consisted of type 1 diabetes, with the rare patient having another form of diabetes. This paradigm has changed, and it now includes a variable number of children with type 2 diabetes, monogenic diabetes, both MODY and neonatal diabetes, other specific forms of diabetes, and occasionally even gestational diabetes. All of this has occurred on the confusing backdrop of a persistent increase in the prevalence of obesity in the childhood population. The predominant reason for this change is the increasing incidence of type 2 diabetes. The other problem with this changing environment is resolving the differential diagnosis. I suspect that the diagnosis of gestational diabetes, neonatal diabetes, and other rare forms of diabetes is relatively easy or uncommon, and the exclusion leaves two main differential diagnoses to consider in addition to type 2 diabetes. These are maturity onset diabetes of the young and type 1 diabetes. For a large proportion of children, this distinction is not a problem, but for a smaller but significant portion of youth, this is more challenging. To consider MODY firstly. MODY refers to a collection of relatively rare monogenic disorders where there is a strong family history of diabetes. These families are usually characterized by having 3 or more generations affected by diabetes, and the pattern of inheritance is that of a dominantly transmitted genetic disorder. The onset of diabetes is usually before 25 years of age, although many of these people are missed. The families are usually antibody negative, and it is said that this is more common in Caucasian populations, but I can't find any data to support this. This slide lists the 5 commonest genetic defects associated with MODY type 1 to 5. However, MODY is increasingly being classified by the genetic defect. There are, to my knowledge, 14 mutations currently identified, and I have listed these on these slides. I certainly do not know enough about each one of them to tell you about each one of them. These mutations cause beta cell dysfunction, resulting in impaired insulin secretion. The impaired functions include dysfunctions of glucose sensing, disorders of intracellular glucose metabolism, and those involving activation of the potassium channel. The affected people usually need to be treated with diet, activity, and low-dose sulfonylurea. So are we not diagnosing these conditions? And if so, how often is it missed? In this study, done in Denver at one of the most renowned pediatric diabetes centers, a cohort of 97 subjects were identified who had features suggestive of MODY. They were tested for 5 genetic mutations known at that time, and 20% of them had an identifiable mutation. The commonest being MODY type 3. Of these, only one had a pre-existing diagnosis of MODY, and 43% were being erroneously treated with insulin. In a report at ESPE in 2015, Andrew Hattersley noted that the majority of cases in the United Kingdom and the USA were not being diagnosed. And that was in the range of 80 to 90% in both countries. And of these, 76% were being incorrectly treated with insulin. In a recent review on MODY, it was stated that 6 to 7% of children who have antibody-negative diabetes have MODY. In my population, that would amount to 0.6 to 0.7% of all the children I see. The other differential is type 1 diabetes. When I was in medical school, I was informed that differentiating type 1 and type 2 was a simple process. This table would have been the kind of criteria used to distinguish these types of diabetes. I have found increasingly that these criteria are not as easy to use in the modern era. I suspect most of you have seen patients where this is very difficult at the time of diagnosis to determine whether they have type 1 or type 2 diabetes. And if you look at each one of these, you will see the difficulty that one faces. Type 1 is no longer limited to childhood, and type 2 diabetes is increasingly occurring in younger people. Not all type 1s are thin anymore, and there are type 2 diabetics who occasionally will develop ketones, particularly as a presenting feature. Insulin is now used for both type 1 and type 2 diabetes, and this distinction is no longer true. In the UK PDS study, 15% of people considered to have type 2 diabetes were actually antibody positive. And I would go on with the rest, but there's a lot of evidence to suggest that none of these factors over here are easily used in distinguishing between type 1 and type 2 diabetes. An increasingly larger proportion of youth that do not fall conveniently either into type 1 and type 2, and I think that this paradigm that we have may be changing. Perhaps we're best left thinking of diabetes as a spectrum of conditions between type 1 and type 2 with a range in the middle. Thus, my old view is probably going to be replaced by a much more fluid model like this. There are obviously children who have type 1 diabetes at the one end of the spectrum, and at the other end of this bipolar model are children who have typical type 2 diabetes. In the middle is a group of children that are the ones that are difficult to classify into type 1 or type 2. And these have variously been labeled as type 1.5, double diabetes, and even triple diabetes, whatever that may be. This model is likely very fluid and changes in shape and dimensions depending on which population you're looking at. And this may be influenced by differences in obesity rates, ethnicity, and presumably other factors. In Japan, the shape has flowed more to the right, and the predominant type of diabetes in Japan and youth is type 2 diabetes, whereas in Europe, it may be flowing more to the left as an example. And you may find that patients fit variously along this model, requiring different kind of therapies as you go along in the course of their diabetes. The adult paradigm has also contributed to this and has created more of a problem. This may be the harbinger of how we're going to see this whole diagnosis of diabetes. Patients with diabetes who are antibody positive and currently called type 1 or type 2 or LADA are being classified as severe autoimmune diabetes. What is currently called type 2 diabetes is evolving into 4 categories. Those with severe insulin-deficient diabetes are characterized by low insulin secretion, poor metabolic control, and the risk of retinopathy and neuropathy. Severe insulin-resistant diabetes is characterized by insulin resistance, obesity, a late onset, and the risk of nephropathy and fatty liver disease. Mild obesity-related diabetes occurs in the context of obesity and occurs with a fairly early onset. And mild age-related diabetes occurs later on in life and has a low risk of complications. Both of these latter two categories are considered much milder than the previous ones with a low risk of complications. As I'll show shortly, youth-onset type 2 diabetes does not quite fit any of these categories. Thus, the challenges that confront us when we think about diagnosis is the difficulty in determining the type of diabetes that all of our patients have, accepting that various laboratory tests are expensive and not readily available and may not help in determining the diagnosis that we were looking for. We also need to be thinking about whether local phenotypes are any different from those found in the United States. Opportunities exist in describing local experience, developing diabetes registers to track prevalence, and developing local and appropriate expertise in trying to distinguish what we are dealing with as we go through this evolving situation. This graph shows the increasing incidence of type 2 diabetes amongst youth aged less than 20, and this was done between 2002 and 2016 and was based entirely in the United States. The different lines represent different ethnicities and show that there's been an increase in all groups. The annual percentage increase is 4.8%, and it ranges from 0.8% in white youth to 8.5% in those with Asian or Pacific Islander origin. But these are American data. What about developing countries? The problem in most of the rest of the world is a paucity of information. I found this publication from 2020, and I excitedly thought that this was going to answer the question. I expect that some of you know one of these authors. Unfortunately, all it showed was the paucity of information from most countries. I counted information from less than 20 countries, and this does not include my country or yours. It did, however, note the startling information that amongst youth with newly diagnosed diabetes in Japan, 80% of them are due to type 2 diabetes. In Taiwan, that figure is 54.2%. In Europe, it drops to only about 1 or 2% of newly diagnosed diabetes being due to type 2 diabetes. However, in the United States, amongst populations that originate in Europe, 14.9% are due to diabetes, type 2 diabetes. I think that this reflects upon the effects of ethnicity in the cases in Japan and Taiwan, and obesity when comparing European populations in Europe and the United States. Speaking to colleagues across the world, this anecdote and the anecdotal experience that they bring forward is that the prevalence of type 2 diabetes in parallel with the burgeoning obesity epidemic. And when one looks at youth with impaired glucose tolerance, a quarter of children are obese, and about 21% of adolescents are obese. There are other data that show the wide range of prevalence across different populations. These figures are prevalence per 100,000 population across different populations across the world. The populations with high prevalence at the bottom of this graph are China, India, the whole population of the United States, Brazil, and Nigeria. The ones with the lowest prevalence at the top of this graph are Germany, the white populations of New Zealand and the United Kingdom, Finland, Austria, and the white UK population. I see that's done twice. The prevalence in subpopulations of the United States shows the effects of ethnicity on prevalence, and they are scattered variously through this entire graph. Unfortunately, Egypt has the eighth highest prevalence in this publication. There are no South African data on this, but we are probably well up there with the rest of them. To summarize the risk factors for the development of type 2 diabetes, we have known for some time that ethnicity seems to have a major influence. Obesity is a well-described risk factor across all ages and different populations for the development of type 2 diabetes. For youth, The onset of puberty increases the risk of developing type 2 diabetes. It is hardly seen in prepubertal children, but the numbers start to increase rapidly once you get to puberty. In almost all studies of youth with type 2 diabetes, there is a preponderance of girls being affected compared to boys. Excuse me. Genetic factors are hinted at by the family clustering of type 2 diabetes, identical twin studies that show an increase in prevalence, and genome-wide studies that have identified variants in or near 7 regions of the genome that occur more commonly in those affected with type 2 diabetes. However, another factor may be in play. The development origins of health and adult disease, previously called the Barker hypothesis, postulates that changes during fetal life, as illustrated on the left of this slide, associated with changes in early childhood, is causally associated with health outcomes in later life. With regards to type 2 diabetes, low birth weight, particularly SGA babies, seem to have an initiating event for the development of type 2 diabetes. When followed by rapid early infant and childhood growth, there's an increased risk for the later development of type 2 diabetes. Developing countries are highly represented in this hypothesis. They have higher rates of low birth weight and SGA babies. They seem to have an intergenerational effect, and it's a problem across generations when one looks at big populations. And these populations are also undergoing significant demographic changes. And these demographic changes are characterized by increasing economic growth and development taking place in countries that have led to changes in diabetes and activity. Think about China and India. Does this cascade mean that developing countries are going to see a more rapid increase in type 2 diabetes in young people? Is this the basis for the ethnic differences being seen? Because most developing countries house all the so-called American-labeled ethnic minorities. You may well ask for the evidence in support of this hypothesis. It has been recognized that 1/3 of youth with type 2 diabetes have mothers who have pre-existing or gestational diabetes in pregnancy. The exposure to maternal diabetes increases your odds for the development of type 2 diabetes by 5.7 times. The exposure to maternal obesity increases your odds of developing type 2 by a factor of 2.8. There is evidence for the association of maternal undernutrition, intrauterine growth retardation, and low birth weight with increased risk of obesity and type 2 diabetes. Among those born small for gestational age, weight gain in the first 4 months of age increases your risk of development of obesity and type 2 diabetes. Obesity in itself is an additive effect for the development of type 2 diabetes. Time will tell us whether this will affect this young population as well. Interestingly enough, breastfeeding has a protective effect in babies born SGA. Here's something else that I'm just going to speculate about, and it gives us something to think about in a post-COVID world. Throughout this pandemic, rates of symptomatic infection in young people has been lower than in adults. We have no idea of the rate of asymptomatic infections, both in adults and in children for that matter. Despite low rates of vaccination, with even low rates in developing countries, the waning of infections suggests that there is some degree of immunity that has been developed in populations. It may also be that the virus has become less virulent. There is a growing evidence to suggest that COVID infection increases the risk of type 2 diabetes in adults. Time will tell us whether this will affect our young population as well, as we have no idea how many of children will be have been affected by COVID and how many of them will be developing type 2 diabetes in the future. So are we on the cusp of an awakening epidemic? We have a well-described obesity epidemic that is starting in very young children and occurring across all of the globe, particularly in developing countries. There may be an influence of the developmental origins of adult disease in this regard, as well as the gastrointestinal microbiome. The GIT microbiome may also contribute to the development of obesity, and changes in the mode of delivery, infant feeding practice, antibiotic misuse may contribute to this change. Social determinants as part of the demographic transition occurring in many developing countries includes changes in dietary practices, which include exposure to westernized diets or to increased intakes of existing diets, as well as decreased activity. The COVID epidemic may have had direct effects on the development of type 2 diabetes, but may also have accelerated in the wrong direction these social determinants. Place these factors in the genetic or ethnic backgrounds or socioeconomic conditions that they are all surrogate markers for, and we could be in for a seriously difficult time ahead. Not only is type 2 diabetes increasing in youth have significant differences from adults with type 2 diabetes. They have been shown to have more rapid deterioration in beta cell function, with a decline of beta cell function of 20 to 25% per year compared to 7 to 11% per year in adults. They have decreased insulin sensitivity by about 50%, and they have increased more severe insulin resistance, more rapid progression of their diabetes, leading to more rapid onset of complications when compared to youth with type 1 diabetes or to adults with type 2 diabetes. It has been shown that 60% of youth onset type 2 diabetes affected individuals had complications within 13 years. So with a potential epidemic of more severe forms of diabetes than we are familiar with, how are we going to treat them? Looking at management options, these have been the options that have not changed and where we should be starting to think about how we treat our youth with type 2 diabetes. I am not going to say much about lifestyle modification, except that there are considerable and possibly higher barriers to achieving this in a developing country situation. Metformin has been licensed across the world, is relatively inexpensive, and has benefits for type 2 diabetes in both adults and children. We have been comfortable as pediatric endocrinologists using insulin for a long time, and this is widely available and relatively and licensed for use in children. And so they're probably going to form the basis of what we should be doing. Insulin has been recommended as a treatment, at diagnosis in many guidelines. The presentation in diabetic ketoacidosis and a high HbA1c, often regarded as being more than 9%, with symptoms are indications to start treatment with insulin. I usually start with a once-a-day long-acting formulation with dose titration to a fasting value of between 4 and 8. As control improves, there's often a need to decrease doses, and I often stop treatment after 3 to 6 months if I'm convinced that the child is well controlled and is a typical type 2 diabetic. I expect that later presentations occur in developing countries, and this may mean an increasing need for insulin therapy in developing countries. This graph shows the benefits of insulin early in the course of type 2 diabetes. The blue bars that indicate subjects who receive insulin either alone in combination with metformin show decreases in body mass index, A1C, and an increase in C-peptide. The effect on HbA1c and C-peptide is greater than with metformin alone or with no medication. We should continue to be vigilant about the effects on body mass index of those receiving insulin, although in this study it seemed to have a beneficial effect. Recent developments have increased our options for treating youth with type 2 diabetes. GLP agonists are one of those, and this slide summarizes the studies done on youth with type 2 diabetes. Firstly, the GLP-1 agonists. On each row is listed the drug being tested, the medications that subjects were on at the start of the trial, the dose of medication given, and the duration of follow-up. The last column shows the benefit of the intervention, and this is usually the difference between the decline in HbA1c compared to the placebo group. The first study here shown here is for liraglutide. And in this study, the subjects were on metformin and some of them were also on insulin. And this was true for all the studies on this slide. Liraglutide was administered at a dose of 0.6 to 1.8 milligrams a day. And at an analysis done at 26 weeks, HbA1c had decreased by 1%. At a second follow-up at 52 weeks, HbA1c had decreased by 1.5% compared to baseline. The second trial is of an extended release formulation of exenatide, which was administered at a dose of 2 milligrams per week. After 24 weeks, HbA1c had declined by 0.85% compared to placebo. The last study used dalaglutide at 2 different doses. At 26 weeks, those on a lower dose of 0.75 milligrams a week had a decrease of HbA1c of 0.6%, while those at a higher dose of 1.5 milligrams had a decrease of 0.9%. Across these trials, there were similar side effects, but significantly, they had no significant effect on weight. 2 other trials have evaluated the SGLT2 agonists and empagliflozin and dapagliflozin and the DPP4 agonist linagliptin. In the first trial, empagliflozin and linagliptin were compared to a placebo in a 3-armed trial. These subjects were on metformin or insulin. In the EMPA arm, the dose was 10 milligrams, which was increased to 25 milligrams at 12 weeks if HbA1c was not under 7%. The benefit in this arm was 0.84%. The 95% confidence intervals are in brackets and suggest that this is a significant benefit. In the linagliptin arm, the dose was 5 milligrams daily, and the benefit of 0.25% was not statistically significant because of the wide confidence intervals. The last trial I know only briefly because I was only able to see an abstract and I wasn't able to get the original paper, and this trial used dapagliflozin against a placebo at a dose of 10 milligrams daily. At 26 weeks, an intention to treat analysis showed no statistically significant benefit. A sensitivity analysis was done, and I have no details of this whatsoever, and the benefit became significant with an improvement of 1.1%. There was a low rate of adverse events in the first trial, but a higher rate of mild effects in 60% of the study group. Again, I have no idea what these mild effects were. Other possible therapies include the thiazolidinediones, and a previous study of rosiglitazone showed a delay in progression to insulin therapy at a time when there was no alternative to treat youth with type 2 diabetes. Sulfonylureas seem to be taking a backseat in adult disease due to the risk of hypoglycemia and weight gain. I have not seen any data in childhood on meglinides or on the sulfonylureas. Where offered, bariatric surgery is another alternative to consider. The problems with all of these new medications and even of surgery is that they are not readily available, they are expensive, and for many of them, they are not approved for use in children, and there's not enough data for the use of them in children. We still need to wait for more studies. We still need to look at the benefits, and we hope that the regulatory authorities do register this for use in children and use for type 2 diabetes in youth. So as a consequence, I have developed my own clinical approach, which has used mainly clinical assessment, clinical factors, and my judgment to assess the probable type of diabetes and determine where in the spectrum of presentation they may fit. I use insulin and metformin quite liberally in type 2 diabetes and find more rapid control of the diabetes. I often withdraw the insulin gradually as dictated by the clinical response, and very frequently would wean them off within 3 to 6 months of age since diagnosis. The clinical course and the response to treatment very often suggests the most likely diagnosis with a little bit more confidence, but that diagnosis is sometimes never known. More importantly is finding the best medication for that particular child, and I find a big range of how they respond to the different medications that you may be able to try on them. Finally, I have no experience with newer drugs, so this has not yet impacted on my practice in any way. Lastly, I think we need to be thinking about how we can prevent this condition. It is not clear whether, like the climate crisis, we are able to ameliorate this coming wave. If we are, then clearly public health measures are the best way forward. These include improvements in maternal health and antenatal care to prevent some of these small babies that we are seeing. The old dictums of breastfeeding, childhood nutrition, and growth monitoring and appropriate screening will be of great benefit, and we need to go and educate our medical community about all of these. We also need to educate them because type 2 is usually asymptomatic in youth, and appropriate screening is essential. Education of the community is essential also for early diagnosis of these children, for management of these children, and for efforts to prevent this condition from occurring. I thank you for your attention, and hopefully I will join you live in a few minutes to answer any questions that you may have. Thank you.
Thank you very much. We are honored by your presence, Professor Kube. I quite agree with you in some points. I think Africa is the same. Type 2 diabetes in children is very aggressive. When we start treatment or diagnosis in a matter of 6 months to 2 years, I find that the patient needs insulin all the time. I quite agree with you again that it could be a preventable disease if you avoid screen time and avoid obesity. But usually I start with long-acting with glucophage. Do you have the same protocol?
Yes, I do. I start them all on metformin and frequently insulin, and try and establish some lifestyle change. And if the lifestyle change takes hold and if you start to lose some weight, very often you find that you can decrease your insulin and sometimes stop it.
Thank you very much, Professor, for a really very interesting lecture. I have two questions really to ask about. One of them is the role of HOMA-IR in pubertal obese children, and if it can be used as a sort of a predictor to the development of type 2 diabetes, because it has been used really, now in Egypt it has been done in so many children. So just I'd like to know your experience about this. My other question is about the use of GLP-1 receptor agonist in obese type 1 children. Yes. Thank you.
If I understood your first question, it's about use of insulin resistance markers like a HOMA index. I haven't seen any evidence that gives you a number that predicts who's going to develop type 2 diabetes and who isn't. I suspect that significant numbers of them will, but I don't think that there's anything to suggest when that may happen. So, as I would say to most patients that I see who are obese, the chances of you developing type 2 diabetes are high without even a HOMA index, but I can't predict when that may happen. So I don't think that I've seen anything that suggests that it's of clinical use to be able to measure an insulin or measure an insulin resistance figure, or however you might derive those, in trying to predict when the type 2 diabetes may happen. I've always been intrigued by the idea of a GLP-1 agonist in the course of type 1 diabetes. And I always hoped that somebody would do the trial, and I would very happily hit that if I had been offered the opportunity of using a GLP-1 agonist early on in the course of type 1 diabetes and see what effects it has. I believe that there are studies happening right now looking at something similar, but I haven't seen any published data on this, and I have no other views on that particular subject.
Thank you. Thank you, Professor Pula, for this eye-opening lecture. I'd like to ask you, have you come across some studies with all this migration going on in the world, comparing people, those who have these high incidences of type 2 diabetes, for example, in a migrant country compared to their original, where they eat their original, they have their original food in comparison to those who move to other countries and eat food that is not usual. Like, for example, Asians are used to eating rice, and then they move to areas that eat high gluten diet.
I'm not sure that I've seen a paper that's actually gone and teased out all those little effects, but there's certainly been a lot of suggestions that you carry over the issue. So, for example, South Africa has one of the highest populations of people from India. Durban is reported to have the highest number of expatriates compared to any other part of the world of type 1 of people from India. In the 1980s, the study was done amongst young adults, and 30% of them were either pre-diabetic or diabetic at a time when India hadn't seen the kind of emergence of the type 2 epidemic in India. But over time, as India's gone through its demographic transition, this number has increased. And then you start to look at Indian populations across the world, whether they're in the UK or Fiji or Trinidad, the United States currently, and any other part of the world, rates of type 2 diabetes are exceptionally high. So I think there's a lot of, if there is hidden information about all of this, that you look at people moving from, especially middle income, low income countries, and moving to more higher income countries, and they seem to have high incidences. I think the American data bears that out as well, that Asians and Pacific Islander populations are considered to have the highest risk. People from Africa seem to have a higher risk than European people do, especially when they move into more developed countries.
Thank you very much. So I think you would...
Okay. Yeah, thank you for a nice presentation and informative lectures. I want to ask about your experience about patients. Some patients you have only on the oral hypoglycemic agent like metformin only for type 2 diabetes in children. And usually for a long time, they stay on the oral only without insulin. This is my questions about this case, because we have a lot of cases when it started with basal insulin and metformin. Later on, they shifted to the insulin completely. Thank you.
Yes, that's my experience as well. You can get them onto metformin alone, and depending on how strictly they adhere to a new lifestyle, you can leave them on metformin perhaps for a few years, but for many of them, eventually they start to require something additional. And because we don't have access to any other medications, then usually they go back onto insulin. And I think this just reflects this kind of very rapid progression you're seeing with youth onset type 2 diabetes as opposed to adult onset diabetes. So I think that is definitely a factor. That is definitely my experience as well, that you cannot survive, you cannot control type 2 diabetes in young people adequately with just oral agents alone.
Any questions from the floor? Professor Nermeen? Yes? You can have the mic.
I want to know your experience regarding these adolescents with pre-diabetic states, with their blood glucose between 140 and 200, or the A1C above 5.7 and below 6.5. Do you carry on how you are fetching on them? You are giving metformin or not? Apart from the lifestyle, we know they have to take care of the lifestyle and the weight, but is there any intervention with the metformin or not?
I don't personally use metformin. I use the risk of them developing diabetes as a very big stick to beat them into some lifestyle change, but I don't use metformin routinely in those children.
Any other question? Yes, Professor Iman.
Thanks so much for your very excellent and illustrative lecture. I agree with you for the use of basal insulin with metformin for treatment of type 2 diabetes. I want to ask, what type of basal insulin do you prefer? First generation basal insulin like insulin glargine, or second generation like degludec, regarding obesity, about using insulin glargine?
In the public sector in South Africa, we only have access to insulin glargine, so that's what most of them go on to. I haven't in the private sector used too much of anything other than insulin glargine. It seems to do the job adequately, so I don't have experience using the second generation ones as yet.
Thank you.
Any other questions? If so, thank you very much. We need to see you next time face to face. Thank you very much for you, Professor Kube. Thank you, Professor عبد السلام. يعني أنا الحقيقة بشكر عبد السلام شكر خاص إنه جاي مخصوص من ليبيا، ومعاه الليبيين أشقائنا، وكل سنة تبقى معانا وتجيب الجامعة كلها بقى. بشكر الدكتورة لبنى، بشكر الدكتورة وئام، والجلسة خلاص.